Good afternoon. I want to thank Mohammed and Louise for putting on such a fine educational seminar. I think education is the backbone of what keeps us all going and doing what we do. So I want to talk a little bit today about how ECMO contributes to kidney dysfunction and participates in the development of acute kidney injury. I don't have any disclosures on this talk, so we should first ask, what is the incidence of acute kidney injury and renal replacement therapy for patients on ECMO? Well, in 2010, Dr. Yan and his colleagues, they published a paper called, in the European Journal of Cardiothoracic Surgery, Acute Kidney Injury in Adult Post-Cardiotomy Patients with Extracorporeal Membrane Oxygenation, and they used the rifle classification and the Acute Kidney Injury Network as their criteria. And they looked at 67 adults aged 37 to 63 post-cardiac surgery who ended up on ECMO. The incidence of AKI in the first 48 hours of ECMO was 83%. And the in-hospital mortality rate, if the patient ended up on RRT, renal replacement therapy, there was a 73% mortality rate. But patients who did not end up on RRT, the mortality rate was 32%. So you can see that there's a huge impact if you have a severe case of acute kidney injury on mortality rates, basically more than double. Dr. Keilstein and his colleagues back in 2016 in Nephrology, Dialysis, and Transplant Journal, they published an article, Renal Function and Survival in 200 Patients Undergoing ECMO Therapy. And they looked at 200 adults aged 17 to 83. All patients received ECMO therapy. And the patients who received renal replacement therapy, 60% of them received it. They had a 90-day mortality rate of 83%. Whereby patients who did not require renal replacement therapy, which was 40% of the cohort, their 90-day mortality rate was only 47%. So you can see how impactful acute kidney injury can be on ECMO. So renal injury, there's a paradoxic progression that happens here. And AKI in patients on ECMO is mainly due to the hemodynamic deficiency associated with the baseline disease. So the patient is already ischemic globally, and that's why they ended up on ECMO, right? So now you have a vulnerable kidney that is then exposed to an additional considerable stressor, i.e. the ECMO circuit itself. So while ECMO effectively supports organ function, it also contributes to maintaining the kidney's dysfunction, and it's through several mechanisms that this occurs. So the aim is to understand these mechanisms that are responsible for maintaining acute kidney injury in the ECMO patients and to identify their physiological pathways. So the factors derived from ECMO therapy that cause or maintain patients to have acute kidney injury, well, there's three. There's patient-related factors. These are generally ones that occur pre-ECMO. Then there's the ECMO-related factors, the ones that occur while the patient's on ECMO. And then, of course, there's cannulation and access-related factors. We're going to look at each one of these. So looking at patient-related factors, the pre-ECMO factors, you look at the patient history. The patient comes to us with a lot of risk factors for AKI already. And if you look at these, renal failure, diabetes, hypertension, infection of some type, COPD, left ventricular failure, peripheral vascular disease, smoker, hyperlipidemia, and they've received contrast. Thinking about this list, how many of our patients have many of these, and in a lot of cases, even all of them, right? They've received contrast if they've gone to the cath lab or if they go to the CT scan with contrast, right? So there's a hypoxia due to the baseline disease. That's the reason they were on, that we had to put them on ECMO. So it's a cardiac or respiratory failure resulting in tissue hypoxia. So you also have now pharmaceutical therapies that are nephrotoxins, and there's a lot of these. Your NSAIDs, ACE inhibitors, diuretics, antiviral drugs, vasopressors. I mean, how many of our patients are on a lot of these? You also have other ones, vancomycin, aminoglycosides, cyclosporin, zoledronic acid, and again, contrast. So the NSAIDs and ACE inhibitors, well, these alter our renal autoregulation, the autoregulatory blood flow to the kidney. And this is always, poor perfusion is always a precursor and our direct cause of renal AKI and renal injury. Diuretics and antiviral drugs, well, they cause swelling and inflammation of the kidney and of the parenchyma tissues. Vasopressors, well, they're going to reduce the renal blood flow, especially vasopressors like phenylephrine, which is a pre-capillary vasoconstrictor and also an afferent artery vasoconstrictor. The afferent artery is the direct artery that perfuses the kidney. Vancomycin and the other ones, well, vancomycin causes renal tissue toxicity. It's directly toxic to the tissues of the kidneys. Aminoglycosides is a tubule toxicity. Cyclosporin, zoledronic acid, in contrast, are all toxic to the nephron directly. So when we look at ECMO-related factors, we have hemodynamic factors, and we talk about the delivery of oxygen. One of our speakers earlier was talking about the delivery of oxygen. Well, we also look at pulsatile flow. So when we are on ECMO, somebody was talking earlier about VV ECMO. Fortunately, we most of the time have the luxury of having a mix of some of the native pulsatile flow and the mix of the ECMO non-pulsatile pump flow. So we're going to look at that, and then we look at reperfusion injury following the ischemic event. The patient has global ischemia, and then so you really have a global reperfusion injury that goes on, and it's specifically with the kidney. Then we also have hormonal factors. We're going to look at the renin-angiotensin-aldosterone response, and then we have the Sears response, which everyone talks about on ECMO, which is a massive inflammatory response. So when we look at the hemodynamic factors and we look at the delivery of oxygen, we look at the delivery of oxygen formula, blood flow times the oxygen content of the blood. And of course that breaks down to the flow, which is Q, times the oxygen content of the blood, 1.36 times the hemoglobin, which is why your hemoglobin content is so important, times the saturation of oxygen, and of course, a very microscopic factor, which Dr. Osborne pointed out could actually be deleted from the formula, is a 0.0031 times the partial pressure of oxygen. So any factor which alters your delivery of oxygen, and I highlighted there in blue and underlined there, your blood flow, your hemoglobin level, your arterial saturation, and your partial pressure of oxygen are going to be things which either increase or decrease your delivery of oxygen. And these will have a direct impact on delivery of oxygen to the tissues and what contributes, in the case of the kidney, to AKI. Things like anemia, low flow states, vasopressors, as I mentioned, any low cardiac output state, hypoxia, emboli, hypovolemia, hypotension. Now, how many of you have seen all of these on any given ECMO run at any given time? Well, when we look at the interplay of the native pulsatile flow and the non-pulsatile pump flow, many studies have demonstrated that there is a benefit of pulsatile flow to the kidneys. All of you who've been in perfusion for any time at all know that there's some not so well explained, we don't understand it fully, why there's a benefit to a pulsatile perfusion. And when you have ECMO, you can have a combination of some pulse and some non-pulsatile. But if you can have some pulsatile flow during your ECMO run, it is a benefit, and you do see a reduction of AKI. We don't fully understand this benefit to the pulsatile flow for the kidney, though, and it's been something been debated for decades. But when we compare cardiopulmonary bypass to ECMO, in ECMO we also often have the advantage of a shared circulation, as I mentioned, the patient's native heart and the ECMO pump. Due to this interplay between the native heart and the ECMO pump, we can also often have the benefit of a pulsatile flow. So you see there in red that you might not have the greatest pulse, but you have some pulse. And this is better than if you had no pulse at all as far as AKI in the kidney is concerned. So let's look at reperfusion injury when it comes to ECMO. So this is kind of a take-home slide, short and simple. Reperfusion injury is, without a doubt, one of the major causes of AKI when it comes to ECMO. Well, why is that, and what is reperfusion injury? Reperfusion injury is caused when blood supply returns to the tissue after a period of ischemia or anoxia. It's a paradoxical tissue response by ischemic tissues following the restoration of blood flow and tissue oxygenation. So you would think that if you have an ischemic tissue, the best thing you could do is restore the oxygen supply to that ischemic tissue. And unfortunately, while that is the case, there's a paradoxic negative response called reperfusion injury. So whereby the restoration of the circulation results in oxidative damage and subsequent inflammation. It is the excess production of reactive oxygen species, ROS, that is the critical factor in the genesis of reperfusion injury. Reperfusion injury is a very complex syndrome. You can look at it and study it we can talk about it for hours, but there's many factors involved, but the reactive oxygen species is a huge factor in reperfusion injury. The dominant cellular and enzymatic sources of reactive oxygen species are, to give you some examples, and there's many, xanthine oxidase, NADPH oxidase, which is also known as NOx, the mitochondria themselves, which functions in the initiation and development of inflammation. You also have something called nitric oxide synthase. It catalyzes nitric oxide, which is a pro-inflammatory mediator that induces inflammation. That's just a short list. Well, what is the pathology and reperfusion injury? What is really going on? Well, reperfusion of ischemic tissues results in microvascular injury to the endothelium, and that's what you need to think about when you think about reperfusion injury, is what's happening on the endothelial layer. That's a single cell lining of our vasculature, and that performs vital functions. And if that's injured or destroyed in many cases, you have a vast response that goes on to that. Well, the injured endothelial cells then produce more reactive oxygen species, resulting in an inflammatory response, and this is largely responsible for the reperfusion injury. This leads to increased permeability of the capillaries and diffusion of fluid across the tissue, swelling and third spacing. As you guys all know, you rarely do an ECMO patient that isn't edematous and third spaced, and we have the CRT machine in there taking off enormous amounts of fluid for days and sometimes weeks at a time. When you have a damaged endothelium, it no longer can contain this fluid into the vasculature like it normally does, and it allows the fluid to shift in between the capillary and the tissues. And by the way, that increased fluid is inhibiting oxygen transfer to the tissues as well when that happens. It's not just a fluid issue. White blood cells then respond to this endothelial damage. When the white blood cells come by the capillaries and see this endothelial that's no longer intact, they come in contact with tissue, with the muscle layer of the vasculature. And they then release a host of inflammatory factors, because this is sort of like a foreign object to them. It's tissue factor activation. And what they release is interleukins, more free radicals, cytokines, macrophages, platelets, and complement. All of this is stimulated as the white blood cells come by and come in contact with your damaged endothelial or the endothelium that's been removed altogether. Oh, okay, are we working? Oh, hitting the wrong one, okay. The white blood cells bind to the endothelium itself, so the white blood cells are going to lay down on the vessel wall where the endothelium was before, and this is going to obstruct your small capillaries, leading to more ischemia, okay? So reperfusion injury, but what happens on ECMO? Well, normally a healthy endothelium naturally contains free radical scavengers. We naturally have those in the endothelium. This is how we manage our reactive oxygen species normally, because this is going on in our system every day when we're exposed to toxins. We breathe in car exhaust, any type of fumes. There's many reasons why we actually produce reactive oxygen species in our system normally, but this is managed largely because a lot of our tissues contain these free radical scavengers. A lot of it's in our endothelium, and so this is how we keep it in check. So the healthy endothelium is capable of doing that, but once there's been a systemic hypoxic event, the event that led to ECMO, this ischemic endothelium now has a decreased ability to release and to provide these protective oxygen scavengers. So the endothelium now is no longer functioning very well to absorb these free oxygen radicals. Adequate circulation then brings in oxygen free radicals that damage the ischemic tissue because the protective function of the endothelium is greatly diminished. So if we were normally bringing in oxygen-free radicals, the endothelium would be able to handle it. But now that the endothelium is damaged, and now they're introducing oxygenation with, all of us use very high PO2s on ECMO, which, by the way, increases your free radical oxygen species. Those come into the endothelium, which is not capable of handling the the ROS, the reactive oxygen species. Restored blood flow introduces oxygen, which now generates new oxygen-free radicals, which damage cellular proteins, it damages our DNA, and the plasma membranes. Damage to the cell's membranes causes the release of even more free radicals. When you have tissue damage releases factors that cause even more free radicals. So you can see how this is a cascading event. Since there's been a global systemic hypoxic event, the event that led to ECMO, the effect is widespread. It's a systemic-wide response what we're referring to here. So what happens on ECMO is that the result is a massive inflammatory response, and this inflammatory response incites interleukins. Interleukins are a subset of cytokines that upregulate our immune response and upregulate the inflammatory response. You have the oxygen-free radicals, which I was just mentioning. These are toxic byproducts of oxygen metabolism that directly cause damage to cells and tissues. You have the cytokines in general, proteins and peptides that mediate immunity and greatly upregulate our inflammation. And that's why you hear about cytokine storm, because these cytokines keep upregulating themselves, and they release more recruitment factors and even produce more cytokines. Then there's macrophages. These are white blood cells that would normally engulf, viruses, bacteria, dead cells, foreign substances. Well, in this case, there is no virus or bacteria in our system. The reaction is the ECMO circuit. And so your white blood cells, your macrophages are out there trying to, engulf these substances. They end up doing this to our normal tissues and our healthy tissues. Then the platelets are initiated. Everybody knows the foreign surface is going to initiate coagulation. They, of course, enlarge and adhere together, and they're going to plug up capillaries and cause thrombosis. And then you have the whole complement system, which is an additional system that upregulates our immune response. They enhance the immune systems, and they also act as macrophages, but in phagocytosis fashion, to clear foreign microbes. But again, there may not be any foreign microbes. They attack our healthy tissues. When you combine all of these things going on, this is why you hear so much about the massive inflammatory response in COVID and in general in ECMO, which we talk about all the time, the serious response. But this is very key, and you combine all these things together, the assault on the kidney can be very significant, which is why something about 85% of all ECMO patients wind up on CRRT, right? Probably close to that. This results in tissue and nephron injury in the kidneys, all of these things combining together. Now, there's also hormonal factors, the renin, angiotensin, aldosterone system, and this is very interesting. Because let's ask ourselves, what is this system? Well, normally, in your normal hemodynamic state, your liver is releasing something called angiotensinogen. This is normally circulating in our system, and it's released by the liver, and it freely circulates in the blood. When the kidney senses a drop in blood pressure, the kidney immediately releases something called renin. The kidney does not like low state perfusion, low blood pressure. So kidney sees low blood pressure, releases renin into your blood. When this angiotensinogen comes in contact with the renin converts angiotensinogen into angiotensin 1. The angiotensin 1 now is in your bloodstream, and you've all heard of ACE, angiotensin-converting enzyme, and this is largely residing in the tissues of the lungs. It resides in a couple other places, but about 80% of it resides in our lungs. And now when the angiotensin 1 comes through the lung tissue, then it gets converted into angiotensin 2, and now we're starting to get somewhere. So as the blood passes through the lungs, the ACE, the angiotensin-converting enzyme, converts angiotensin 1 into angiotensin 2. And angiotensin 2 is what you want to focus on, because angiotensin 2 is a very powerful arterial vasoconstrictor. And remember, this whole cascade started when the kidney released renin in response to a low blood pressure. So angiotensin 2, arterial vasoconstrictor, but also does something else. Angiotensin 2 directly stimulates the adrenal gland to release something called aldosterone. Aldosterone is antidiuretic. This is important because if your blood pressure is low, you don't want to be producing a lot of urine. You want to decrease your urine output, which is what the antidiuretic does. So between decreased urine output, you're going to hopefully increase your blood volume, or at least keep it up. And so between these two things, the angiotensin 2 is a arterial vasoconstrictor plus an antidiuretic response, which is going to hopefully increase your blood pressure, which was the point all along. The reason I bring this up is what happens on, by the way, on cardiopulmonary bypass in the OR, but to a much larger extent on ECMO. In a paper published by Gorin way back in 1986 and his colleagues, changes in serum angiotensin converting enzyme, ACE, during cardiopulmonary bypass, this is what they looked at. And they found that immediately after the lung was isolated, when you went on perfusion in the OR and bypass, immediately when you went on bypass, as you know, very little, if any, blood is passing through the lungs. Well, your serum ACE activity fell almost immediately. After 20 minutes of bypass, ACE levels reached 1/3 of their baseline levels. They were decreased by 67% only after 20 minutes of bypass. However, once you restored perfusion to the lung, took the cross clamp off and got normal perfusion going to the lung, serum ACE levels rose back up to 90% of their baseline values within 10 minutes. The reason I bring this up is because when we look at this system, what's happening on ECMO? Well, the decrease in blood pressure, as I mentioned, prompt the kidneys to greatly release renin. However, renin and ACE may be greatly reduced or blocked altogether, resulting in severe vasodilatation, low blood pressure, poor renal perfusion, and as a possible cause of AKI. I'm going to show you this in the graphic in a minute. So when on ECMO, but how is the renin or ACE limited or blocked altogether? How is this happening or why? Well, the decrease in blood pressure is going to prompt the kidneys to release renin, but the kidney may not be capable of releasing the renin because of the acute kidney injury of the kidney itself. In VA ECMO, a large proportion of blood bypasses the lungs, which limits the conversion of angiotensin 1 to angiotensin 2. The blood has to pass through the lungs to come in contact with ACE to get your angiotensin 2 produced, but on VA ECMO, that's not happening very much. So in patients with ARDS, the injured lungs produce less ACE, right? You have a damaged organ, a damaged lung. It's not going to be capable of functioning normally. It's naturally going to produce less ACE, and therefore you're going to produce less angiotensin 2. Now, there's other conditions, such as sepsis, where endotoxinemia can also deactivate angioconversion enzyme. So this results in much less ACE being utilized. So the results in severe decrease in blood pressure and decreased renal perfusion. Decreased renal perfusion is going to lead to AKI. But let's look at how this happens on a graphic. It's easier to look at. So as you started off earlier, we have angiotensinogen circulating through the blood, naturally released by the liver. The kidney sees a drop in blood pressure. It releases renin, wants the blood pressure to go up. Converts angiotensinogen into angiotensin 1. Then the angiotensin 1 is going to pass through the lungs, coming in contact with ACE, which is going to convert it into angiotensin 2, as I mentioned before. However, on ECMO, in most ECMO settings, you either have much less or even no renin or ACE being produced because of the acute kidney injury and the lung injury. So if you have very little angiotensin 2 being produced because you cannot produce your renin or you don't have very much ACE being produced. So instead of having arterial vasoconstriction, which your angiotensin 2 would have done, you end up with lack of vascular tone. You end up with arterial vasodilatation. You also don't have the angiotensin 2 stimulating the adrenal gland to release aldosterone. So instead, you don't have a decrease in urine output. You either have the same or perhaps more. Both of these things, drop in vasoconstriction or vasodilatation, decreased blood volume because urine output stays up, is going to decrease your blood pressure. Decreased blood pressure can result in poor renal perfusion, which is another cause of AKI. So the whole factor of ECMO and renal injury and lung injury is one reason why you guys see so many people on CRRT. So let's look at the inflammatory response, the SEERS response that we talk about so often. What is it? SEERS is the consequences of a dysregulated or a hyper-inflammatory response, which all of us saw almost routinely on our COVID patients. It can be due to an infectious, or it can be due to a non-infectious insult, which is the case due to the artificial surface in ECMO. SEERS universally occurs during ECMO. There's no such thing as an ECMO that doesn't have a SEERS response, at least to some extent, and is associated with organ dysfunction and considerable mortality. So what is happening on ECMO, and by the way, on bypass also? Well, the blood is being exposed to the extracorporeal circuit, as you know, and something called blood shear stress is really what is at the core of this. So if we look at blood shear stress, and it's going to happen on any artificial surface that we're pumping the blood through. One thing that's going to happen, you all know, is going to be you're going to disrupt the coagulation system, and you're going to develop likely some type of coagulopathy. And you're also going to develop a systemic inflammation. So these two key things, there's more than this, but these two key things, if you focus on this, you'll see where this leads. Well, in the systemic inflammation camp, there's a release of neutrophils. You've all heard of a neutrophil storm, massive white blood cells responding because they think there's a foreign invader. Cytokine storm, which upregulates your inflammatory response, among many other things. Your oxygen-free radicals, which I mentioned, and your complement activation, which also upregulates your immune response. On the coagulation side, you have a coagulopathy developing. We just heard a talk from our pharmaceutical doctor that it's very difficult to balance the anticoagulation on ECMO. Well, because you always have an activation of platelets. Then you have an activation of your coagulation factors. And of course, you're going to have thromboxane A4 release, which recruits more platelets. All of this can lead, and often does lead, to hypercoagulation. Well, as you know, if you have coagulation, the coagulation system immediately stimulates you to develop and instigate your fibrinolytic process. So now you have fibrinolysis going on. And of course, between these two things happening, if your high coagulation system overwhelms your fibrinolytic system, you could easily have microvascular thrombi, which we see in 100% of our oxygenators, by the way. All studies that I've ever seen, if you cut in half your CardioHelp or your Quadrox oxygenator, 100% of them, no matter what your anticoagulation strategy is, you will find clots in your oxygenator on ECMO. On the systemic inflammatory side, let's look at each one of these. Neutrophil storm. It's a mass neutrophil migration, and you also have thromboxane release and prostaglandin release. All of these upregulate even more neutrophils. You have hyperinduction and auto-amplifying of the cytokine production. That's your cytokine storm you hear about all the time. Your oxygen-free radicals are very tissue damaging. They attack lipids, you attack your amino acids, your DNA, your RNA, and even your lysosomes. And on the complement side, this is a protein cascade that promotes more cytokines, more phagocytes, and membrane, and something called a membrane attack complex. So the result of all this is a massive inflammatory response, which incites renal tissue damage and AKI. And if you combine all of these things I just mentioned, the interleukins, free radicals, cytokines, macrophages, platelets, and complement, you can see where that leads to. So let's look at the last thing, which is cannulation and access-related factors that lead to AKI. Well, distal limb ischemia can happen due to cannula placement in the femoral artery. We all know that. That's why we now use, it's pretty much standard of practice, use a DPC, distal perfusion catheter. You can still develop compartment syndrome if you have a venous cannula that's obstructing the venous return to that leg. Even if you do have a DPC in, you can still develop compartment syndrome, and that can lead to fasciotomies due to tissue limb ischemia and edema. You can have hypermyoglobinemia, which is when you have ischemic muscle damage that releases myoglobin in the blood. You can have retrograde aortic dissection. We've all seen that if you put in if you damage the femoral artery when you do a femoral artery cannulation. That is not very far away from your renal artery. And if you have a dissected aorta, you can easily have renal ischemia. You can easily have thrombosis or air embolism. The thrombosis we just discussed with our coagulopathy. You can easily have micro air being pumped into the system from one source or another, and that can go down the renal artery, resulting in renal ischemia. And then, of course, your negative pressure hemolysis. You know, we talk about very high negative pressures when we monitor our CardioHelp, and I know at our center, we have a very large ECMO center. We started off trying to keep our negative pressures at 50 to 70, then it was 90, then it's a 120, and as someone mentioned earlier, you can see them as high as 150. And we continue to run the ECMO like that because it seems that we're supporting the patient. We don't seem to be having hemolysis. That's probably patient dependent. But if you do have hemolysis due to that or anything else, and you have hemoglobinuria, as you guys all know from your perfusion education, free hemoglobin, very damaging, nephrotoxic. So when you combine any or all of these that's going on, and these are just the cannulation aspects of it, in addition to all the other ones I talked about, can lead to acute kidney injury. So in conclusion, ECMO is an effective support therapy for patients with reversible cardiac or respiratory failure, and as you all know, a bridge or transplant or a durable VAD. It's clear that renal replacement therapy is usually required and provides management of fluid overload and is beneficial in removal of some of these inflammatory mediators I discussed. AKI is frequently observed in ECMO patients and is related to several conditions derived from the ECMO extracorporeal therapy. These are mainly hemodynamic, hormonal, and inflammatory in nature, as I reviewed. The severe conditions of patients and many variables of this complex treatment usually do not allow us to exactly identify the pathophysiological mechanism that is actually responsible for the development of the AKI. Just too many of them going on. But paradoxically, the various pathophysiologic pathways responsible for the development of AKI during the ECMO are the same ones which produced the pathological conditions requiring the ECMO. And I just go through all my references right here, and I thank you guys so much for listening.